I have something embarrassing I need to admit. In the making of this talk, I've had more Diet Coke than in all of my 22 years of living combined. So everyone knows that the sugar in soda is terrible for your teeth, and yet I continue to drink it, and every time I have a new cavity and my dentist asks me if I've been drinking soda, I tell him that I don't. Think about your own guilty pleasures. Why are you ashamed of them? What influences the things that we find as socially acceptable? The answer is in the question. Society is what dictates what we find as moral or good, and from this, stigma is born. Stigma is defined by sociologists as a deeply discrediting attribute which reduces a whole and valued person to a tainted and discounted one. I'm lucky that my guilty pleasure isn't enough to turn me into a stigmatized person. I imagine that yours probably isn't either. But not everyone is so lucky. For those whose choices turn them into what experts call marginalized people, this can have massive negative effects. Marginalized populations are groups of people who are heavily stigmatized because of some proscribed behavior or socially disadvantaged position that they find themselves in. This includes drug addiction, sex work, incarceration, or homelessness. So what do these populations look like in the United States? When we picture a homeless person, we probably think of an adult who is unfortunate or maybe irresponsible. But the reality is much grimmer. The US Department of Education states that since 2008, the number of homeless students enrolled in public schools has increased by 90%. This means that in the 2013 to 2014 school year, over 1 million students were homeless. For young people aged 20 to 30, increased rates of drug overdoses has largely contributed to a drop in the US life expectancy for the last 3 years. From 2016 to 2017 alone, there was a 10% increase in deaths due to drug overdose, with 45% of those being from the use of synthetic opioids such as fentanyl. For perspective, the US is the only developed country in the world to see this drop in life expectancy. Because of the stigma members of these groups face, there's a resultant gap in the way that they receive support. For example, I've volunteered at homeless soup kitchens many times, and I imagine that many of you have also. What we don't consider is how difficult it might be for homeless people to actually go to these soup kitchens. They might have strict rules such as not being allowed to bring a pet, having to wear clean shoes and a clean shirt. And when you don't have the money for basic hygiene, and your pet is your only beloved companion, this can make it almost impossible to get even the simplest of needs met, like food. This can result in perceived stigma, which sounds like, I don't deserve help, or I did this to myself. Social stigma results in a gap in our understanding of what we think marginalized populations need versus what they actually do. A way to try to bridge this gap is through the use of an incremental approach which tailors future treatments and programs to more realistically serve marginalized populations. Harm reduction comes into play by seeking to remove the barrier between asking for and receiving care. It refers to practices, programs, and policies that aim to reduce the harms associated with socially delinquent behaviors. These strategies were developed during the AIDS epidemic in response to increased incidences of infection that were linked to needle sharing. And yet it's still not in the mainstream, especially here in the US. Such strategies enable us to empower marginalized populations to seek help and better themselves. This stepwise method allows us to create programs and policies from those practices that create a stable foundation on which marginalized populations can establish trust. Instead of waiting for the change to come from the top down, communities can serve and support these marginalized populations that are ready to accept help, and then we can build from the bottom up. Just as guilty pleasures are present in our day-to-day lives, harm reduction practices are too. Washing your hands before you eat your food, putting your kids in their car seat, or brushing your teeth to prevent cavities. Practices are the cornerstone of harm reduction. Their accessibility by both the marginalized populations that they serve and the communities that put them into place make them surprisingly pragmatic. In Copenhagen, I volunteered for an organization that allowed me to pack meals and drive them out to locations with large populations of the homeless. Here in Tulsa, organizations do things similarly. Untitled Tulsa brings clothing, food, and other necessities to the needy, usually setting up in underpasses where homeless people sleep. By meeting them where they are, rather than expecting them to drop everything and show up, this allows us to create a foundation that later makes programs successful, which is the next step in bridging the gap. Classically, harm reduction programs look like safe injection sites, needle exchange programs, or housing first projects. But they can target populations more generally and still be incredibly effective. Studies show that marginalized populations are 25 times more likely to contact a primary care physician and yet see a lower rate of contact with specialists, labs, and therapists who provide them with essential follow-up care. They also delay seeking care, and once they receive it, force discharges before healthcare professionals are ready to send them home. A pilot social nurse program at Bisbee Bay Hospital helps bridge the disparities in care that marginalized populations experience simply by advocating for them. Consider the incredibly vulnerable position that you put yourself in to admit your wrongdoings and mistakes to someone in a position of authority. I know I feel this way when my dentist asks me about how often I've really been flossing. For marginalized populations, this feeling is amplified. Imagine asking your doctor for substitution treatment while you carry the burden of the stigma of addiction that you experience in your everyday life. What makes the social nurse program successful is that it allows patients to build trust with providers while also allowing clinicians to opt out and find someone who is more comfortable delivering the care that these populations need. This is possible simply because harm reduction accepts the situation for what it is. When we accept that marginalized populations require a different standard of care and that not every provider will be able to supply it, we better equip those that are able to deliver them the best care possible. Imagine how much more comfortable you would be at the doctor if you knew you had someone to advocate especially for you. Arguably, the next step in harm reduction is policies. However, these are too often difficult to reach. This is a result of the stigma that these groups face. The good news is that practices and programs are more than enough to target their needs, and so policies don't need to be seen as the gold standard for harm reduction. Despite the challenges in reaching the policy level, the real-world impact of practices and programs is profound. They empower marginalized groups to advocate for themselves and their health and well-being. And by implementing these strategies into our communities, we can minimize the gap in our understanding of the care that they need and the reality. So next time you hear about how full homeless shelters are, or the growing extent of the opioid epidemic on the news, put yourself in the place of these marginalized populations and mind the gap.